Waiting for a signal.
November 13th, we're here with Thomas. He's from, what city do you live in, Thomas? Abbotsford, Wisconsin. Complaining of not being able to bring your shoulder up for 2 weeks, right? 3 weeks? Can you try to bring it up now? Okay, try to bring it straight out from your body and bring it up. That's as high as you can go. Okay. Would you be happy if you could bring it up in a few minutes? Okay. Well, let's do one at a time. And we'll go from there. We are on Thursday. It's actually, that's the proper time, 10:24, as you see on your screen, and it is now 4 days later. Russell, could you bring your arm up now? And there it is. Okay, bring it out. Bring it up again. Okay, so you can pretty much get it up now, right? So we see significant improvement. 2 sets of injection therapies. A neural therapy, the first time a neural proliferative or reconstructive injection therapy just accomplished a few minutes ago. We'll zero in on his shoulder. You can see there's a little bit of yellowish bruising on the shoulder from previous injections. Expect him to do very excellent. Needs a few more to get maximum results. We'll stop when he gets maximum.
Can we stop that for a second? The reason we didn't get a lightning the very first session, I got the lightning the second, was I ordered the x-rays with the first visit, and then I looked at them with the patient on the second visit, and I could see he had glenohumeral spurring calcification, so I directed my neurotherapist to the glenohumeral calcifications, and then looked at lightning. So sometimes x-rays can do that.
Okay, so you can pretty much get it up now, right? So we see significant improvement. 2 sets of injection therapies. A neural therapy, the first time a neural proliferative.
Yeah, maybe just put it in fast. Okay.
Okay, you can walk around a little bit. Okay, come on back in and get down in the chair just as fast and as good as you can. Okay, now get out. Fast as you can. Okay, get back in. And get out just as fast as you can. And get back. Okay, could you try to...
Yeah, that's
Yeah, okay. Now get out just as fast as you can. Okay, now would you please kneel down? Yeah, get down on your knees. Well, just do what you can. That's the best you can do. Okay. So the time is 9:02 on January 22nd. Get up now. This is immediately after treating both knees. And back down. And up as fast as you can. And down as fast as you can. Up as fast as you can. Down as fast as you can. All right? And down. Now would you try to kneel? Roll onto the table if you wish. Okay, it looks like a lot further. Okay, how does that feel? Wait just a second.
It feels much better.
Is there more motion?
Yes, almost double.
Not bad for a start.
Okay, that's enough. So now we're going to start with, how do we do that? A little bit more on how we do it. Can we have the lights, please? Because I'll start with the slides here.
Turn that one off down there.
Yeah, this is a horror show now. Next slide. We can land on the moon. We can send ships past the face of Neptune. We can send telescopes to the edge of the solar system, and even peer at the origins of the universe. But yet, day after day, throughout the United States, North America, and the world, people are told by the finest scientists and physicians that they just have to learn to live with their pain and their suffering, that there is no alternative. Well, after being a member of the American Pain Society and finding that that was their goal, I knew to get the heck away from them. And we established ourselves. We have a tremendous problem because we have Milwaukee Pain Clinic, and there's 1,100 of them in the country, and people automatically have a knee-jerk reflex that we're going to help them live with their pain. And we find that disgusting goal and totally not worth the, or compatible with our purpose on earth, is to realize our maximum potential, and then certainly not living with a pain or a disability. And we're going to penetrate that further with this discussion on reconstructive therapy. Next slide. For example, this man is featured in my book, which is available from the Academy. This man is on page 188 of the book. He was totally crippled for 15 years with extremely degenerated knees. He could not get out of the side chair without his wife grabbing on one shoulder, myself grabbing on the other shoulder, and doing 1, 2, 3. Him pushing as hard as he can, walking the 2 steps to the examination table to treat his knees. He had bone-on-bone degenerative disease. His mode of transportation was wheelchair and walker. So he could not go to the bathroom himself, could not do really any type of mobility himself. And he was a youngster of 86 when he started at the clinic. Next slide. After a year of therapy, his wife gave me this Polaroid. I made it into a slide. And you can see there he is mowing his lawn. The book is out of date already, although it was just released a couple months ago. The book says he's 90 years of age. He's 91 now. He had a birthday since the book went to press. He's still totally independent. We had our book signing party at the clinic, and he came and walked up independently. He's been totally independent for 4 years. He was too old to operate, so what the surgeon said. So I guess he was kind of lucky in that fashion. So there are ways, as long as the cells aren't dead. So at the Milwaukee Pain Clinic, we decided to add a second name, Metabolic Research Center, to let people know that there's something different about us. They might not know what, but we get confused with the medical college has one called Milwaukee County Pain Clinic, for example. So words are very powerful things, and we found this turned to be a bad one, but we've been that for 9 years. So we just added a second name. Well, then we run out of money for typeset. But that's a good idea. So again, we were talking about goals in the last lecture. Well, what are the goals with university medicine for pain? treatment, or the orthodox medicine and surgery method of joint treatment? Well, the goals are to block pain. Block the inflammation. It's terrible. Let's block it with NSAIDs and aspirin, Indocin. Let's remove the torn and frayed, roughened structures and torn and bad. Get them out of there. And let's replace them with cobalt chromium or magnesium or titanium, right? Nickel, cobalt, whatever. That's their goals, basically. Next slide. In biological method of joint treatment, we want to, number one, optimize the body's healing ability, detox, gentle manipulation, exercise, sauna, steam bath, nutrition. And then two, if that doesn't work, your primary, rest, if that doesn't work, then stimulate controlled inflammation, which is the body's own healing mechanism. Goal-directed, as Dr. Alvarado said, and Dr. Dookie, to cause a permanent natural reconstruction of structure. And we'll get into that. In fact, this whole lecture is on that, how we do that. Next slide. Here we have a normal joint. This is the knee joint without patella. We have, because it's a weight-bearing joint, it has shock absorbers, menisci or disc or cartilage. And it has the primary stabilizers of the joint, ligaments. Next slide. Well, ligaments do three things. They stabilize the joint, they limit the range of motion of the joint, and limit, okay, I don't know why I have a block. They limit the range of motion of a joint, and they're the primary stabilizers of the joint, and they are passive structures, which means that you cannot contract them at will. Is another one of their functions or characteristics. If you should tear a ligament or a tendon, which is much the same, they attach to a bone and have poor blood supply, they will most likely tear on the emphasis or the seams or the fibroosseous junction. It's similar to if you tear my shirt, you're going to tear it at the seam. Next slide. There are degrees of sprains. Sprains are ligaments. Strains, got a T in it, so it's a tendon. There are degrees. There's a little bit, there's more, and there's a heck of a lot. Next slide. Wolff's Law. Bones respond to stress by making more bone. So here's the mechanical etiology of hypertrophic spondylosis or arthritis. Bones respond to stress by making more bone. If the ligament, the primary staple of the joint, is weakened, next slide, the bone responds to the friction, because it's unstable, and makes more bone to stabilize it. So the body is trying to help you in spite of the abomination that the medical community is doing to it. Next slide. 35% have arthritic disease from knee and cartilage surgery in less than 10 years. So even the surgeons are noticing wonderful results from taking out body parts, structural parts. James Fox of the Southern California Orthopedic Institute. Next slide. Here's a knee that through maybe wear and tear, inadequate nutrition, toxicities, has worn away the disc space or the cartilage space, and therefore making the ligament lax. Therefore, bones, it has increased friction. Bones respond to stress by making more bone. It's a law. It has to occur, Wolff's Law. And you get the spurring to try to stabilize the joint. Next. So here we have illustrated, we have a normal disc height, and we have normal vertebra or bones, and we have taut, T-A-U-T, ligaments stabilizing that joint. With the loss of disc height, this causes an instability of the stabilizing ligaments. It causes them to become flax. So when it's higher, it has a spacing function, it makes the ligaments taut. When you lose that height, the ligaments are going to be just as long, but they're now going to be unstable and untaut, not tight, causing propagation of instability, illness, change in the whole artery cycle starts. So with the loss of disc or bone height, this can cause instability of the stabilizing ligament. So if we lose space here, we lose space on the joints themselves or the bones themselves, and compression fractures, etc. It's going to make the ligaments more lax. With reconstructive therapy, we actually cause a reconstruction or rebuilding of these ligaments, and also a shortening, because fibronectin is secreted in the process, in the inflammatory process, and that causes an increased coiling of the collagen, resulting in a shorter ligament as well as a stronger ligament. Next slide. This man is who, Dr. Dookie?
His name is with S.
No, his name is with R and S.
S.
This is Dr. Dookie referred to him, and this is the Austrian philosopher, Dr. Rudolf Steiner.
Yeah.
Dr. Steiner, along with Dr. Reckwig, along with Dr. Hahnemann, said that inflammation is the body's own, in your words, goal-oriented process. It is the body's own healing process, inflammation. Some of the things Dr. Steiner did, as Dr. Dookie pointed out, was could you go back to Dr. Steiner, please? He pointed out that the elements, he described the elements on the moon some 50 years before we landed on the moon. He died in 1925. He pointed out that a tree, leaf, and the lung alveolus were really very similar, except opposite. One absorbs oxygen, the tree leaf, and releases, the tree leaf absorbs carbon dioxide and releases oxygen. The lung has a similar apparent structure and absorbs oxygen and releases carbon dioxide, and many other very astute theories which have been applied to agriculture, medicine, child rearing, mining, etc. So we attribute him as the modern philosopher of reconstructive therapy in making popular once again, although it dates clear back to Hippocrates, that inflammation is the body's own healing response. Next slide. Curiously, not long after he said that on the European continent, American researchers working independently, two osteopathic physicians, Gedney and Schumann in Philadelphia, and George Stewart Hackett, an allopathic physician in Canton, Ohio, started putting irritants into ligaments, tendons, and joints on the North American continent. This is from Hackett's out-of-print book, in which he injected rabbit tendons 3 times with irritating biological solutions. The one on the right was injected 3 times. The one on the left was injected 3 times with normal saline solution. Hackett sacrificed the animals, measured them and weighed them, and found up to 35 to 40% increase in weight and in size, as opposed to the uninjected rabbit tendon. Next slide. Dr. Hackett took x-rays of these same tendons and found a bigger fibroosseous attachment, and of course the bigger size, as opposed to the non-injected rabbit tendons. Next slide. So basically, reconstructive therapy, formerly known as sclerotherapy or prolotherapy or proliferative therapy, we changed the name in the book because those first 3 terms are misunderstood, and words have power, and we wanted to get the best word. So we used the term reconstructive therapy. But basically, the process is done by introducing a fine needle into the fibroosseous junction of biological irritants, and there are hundreds that can be used. And next slide. And this inflammation, or this irritation, causes a dilation of the blood vessels and signals fibroblasts, which are healing cells, to migrate to the inflamed area and lay down protein or structural collagen. Next slide. Structural protein, collagen, is produced in response to a biological irritant placed at the fibrosing junction. Next slide. So the result is we get more collagen, we get a stronger, permanently repaired and stabilized joint with the body's own tissue. Scientific data, which was conducted at the request and the urging and the spearheaded by Dr. Harold Walmer, who has now left us, has made his transition, but he's totally responsible for these 2 studies done at the University of Iowa. They demonstrated that sodium mortarate, which is a derivative of cod liver fish oil, increases structure and strength of tendons and ligaments up to 40% over normal. This was published in Connective Tissue Research in 1983 and further published in the Journal of Orthopedic Research in 1985. At the University of Iowa, they did Hackett's work more elegant. They did electron microscopy studies, and then they did force transduction studies where they actually pulled the ligaments off the joint and noted that there was an increase in strength of 35 to 40% over the control injected rabbit tendons again. And rabbit ligaments were used in both of these studies. Next slide. A double-blind clinical study was done.
Do you get the addresses of those treatments for some?
They're in my book.
Oh, good.
Biological dentistry gets the money, we give them to them at cost, but they're in the book, and then you just do your library will pull the actual studies. They are scientific studies. This one you can get at your library, because it's relatively recent. But a double-blind human study was conducted in which 81 patients were divided into 2 groups, 40 and 41. They had low back pain from various etiologies which did not respond to any other treatment, drugs, surgery, acupuncture, manipulation, any therapy. They were unresponsive to. On the average, they had 10 years of low back pain. The patients were blinded, the physicians were blinded, so that they did not know what solution they got, either the patient or the physicians. They gave them 6 series. The control group got saline and sham manipulations. The treated group got proliferative solution and real manipulations. In order to blind the manipulations, they had the same doctor give manipulations to both groups. The results were that 88% of these chronic low back pain patients got marked to moderate improvement. Remember, they're 10 years average duration. This was published in the Lancet, July 18th, 1987. It was conducted from a grant from the Sansum Medical Clinic in Santa Barbara, California. Now this, Dr. Alberto and Dr. Apparetto will find is a very pregnant slide because it might summarize their 55 slides that they had on this topic. And Dan asked a good question yesterday. But the inflammatory process is an extremely complicated process when you get all the players in it. But I've summarized it from this excellent article. But basically, there's 4 basic events. The first one is, after the irritant is introduced, is that white blood cells, or hematologic elements, go to the area. And they're monocytes, they're leukocytes, they're macrophages, and fibroblasts and platelets seem to be the main players. They become activated, and you can see we made a Pac-Man, and they start eating up. When these hematologic elements become activated, the proper word, Dr. Dookie, is not mutagenic. In the American literature, it's mitogenic. Mitogenic, meaning they release growth factors or mitotic activity to get new blood vessel formation, angioneogenesis is in the literature that inflammation causes. So you get a new pipeline, you get new blood supply to the area. You get mesenchymal cells mitogenically dividing, not mutagenic. That has a little bit different translation. But mitogenic, you get cell division of mesenchymal cells. You get actually increased cellularity. And 4, the fibroblasts become activated and spew out this stuff, collagen, new structure. Now, this is not theory. This is not hypothesis. This is fact. And I just picked one article, and for those that want to get the actual articles, this is from Clinical Orthopedics and Related Research, number 200, November 1985. It's by Simons, David J., Fracture Healing Perspectives. So this is based on fact. This is the inflammation reaction and healing reaction that you get from introducing a controlled trauma or chemical irritation. I just picked this one. This has 180 references in this article. It good doctors 180. I just picked one. If I picked all the references, well, Ed has them. They have 859 sheets. And there's probably maybe 2,000 references on fibroblasts is what I did a hell of a lot of work to make this one slide, basically, and summarized it. That's the actual summary of what happens when you induce inflammation. But these are growth factors that are released from these hematologic things that cause these other 3 things to occur. So actual mitosis or mitogenic, they call it fibroblast growth factor, angioneogenesis growth factor, platelet-derived growth factor. There's a slug of growth factors that are released from these monocytes, leukocytes, fibroblasts, platelets. So next slide.
Bill, I think the mutagenic part of that whole thing.
Mitogenic. Please use mitogenic.
No, but the mutagenic part that they were referring to is when that particular site becomes a fibrosite.
Yeah, but I like to think of that as mitosis and not mutosis. I think of carcinoma when I think of mutagenic. But changing to a different
Yeah,
form.
it changes this much.
So I would prefer using, and the American literature does not say mutagenic. It says mitotic is the word they use. If you would pull out the literature from this article.
Yeah, yeah.
It's a small point, but I think it's important. You don't want to produce mutagens in your patient, do you?
But again, it's just what you're saying is that the cell takes on different functions.
Well, these are embryological. The fibroblasts, the reticulocyte, are embryologic stem cells which are non-differentiated, which can transform into different material. And the inflammation activates them by having these mitogenic factors. Go ahead. Here we have the low back. We have the disc spacers. We have the stabilizing ligaments. Next slide. Please. We have a torn ligaments. We have loss of disc height. We have a resultant spurring to stabilize and a resultant laxity of the ligaments. The divots that somebody asked me about yesterday. We know that there's nerve-referred pain, but also sclerotomes. There's bone-referred pain, and ligaments and tendons also refer pain. So the black dots can be ligament or tendon enthesitis, problems where they attach to the bone, and their referred pattern can mimic herniated disc or nerve pain, sciatica, and actually is from ligaments. This is from Hackett. We just redid it. Next. So the process is the same. We inject our solution at the fiber osseous junction, and we get an increase in strength and structure. Same for an arthritic spine, in that these are relaxed because we get the shortening, because fibronectin is secreted from the white blood cells also. We get a contracture or an increased coiling of the collagen that's produced, so it can help this situation. This guy's in trouble, but basically, there's our radiology department. We go over all the pictures with the patient. We think that knowledge is the first step in a curative situation. So many times they've been to these fabulous institutions and they just tell them, well, your x-ray showed this. Well, we like to show them. Well, one of my diplomas from Missouri, so we show them. And be surprised how many people don't know that they've had body parts removed. And we'll get into that. Normal hip. Arthritic, lax, torn hip, reconstructed hip, the ankle main stabilizing ligaments, we didn't do the forefoot, torn and relaxed, and reconstructed. Cervical spine. I'd like to point out there's a book called Biomechanics of the Spine by White and Punjabi, Harvard and Yale hot dogs. And they point out in that book that the ligamentum nuchae, this guy, has doubtful clinical significance. So in other words, the creator or whatever made the cervical spine, and you can see here's the front, here's the back, and you have this broad thing here. It's about a third the size of the entire cross-sectional dimension of the neck. And our Harvard and Yale people say in a scholarly book, Biomechanics of the Spine, that this has doubtful clinical significance. So no wonder you just have to live with pain. I mean, God made a huge error, and it's like the appendix is doubtful, so let's cut it out. Doubtful significance. That's where we're with dinosaurs and stuff. The thymus. Well, this is doubtful too. It's not my words. It's Harvard and Yale saying it. I just want to point it out. Next slide. Well, this is what happens with you have small base, huge structure. But in nature, we're capable of doing that miracle of supporting with a small base, huge structure. You don't see that in man-made objects. Small base and then huge, and then mobile structure on top of it. So with just looking down at a computer, looking down at an assembly line, you can get an overstretch. If you have an acceleration, deceleration injury, you can get a rip or a tear, as we found in several people yesterday. And this non-significant structure can become lax and torn. Well, they need to, I guess they're too much in the forest and they forgot the structure, what the function of ligaments is, the support. I thought that was Anatomy 101. But when you go to Harvard, you forget Anatomy 101. Or Yale. So next slide. And here it is, torn and stretched. The result of spurring, the loss of disc height. And again, we have the ligament and tendon tone pain. So it can be coming from these areas and giving pain into the temporal, into the brow, into the nose, into the mandible, the maxilla, the arm, the face, all from ligament or tendon instability. The results of reconstructive therapy in the neck are absolutely magnificent. It's the most exciting area of the body to treat, although reconstructive therapy is an exciting therapy wherever it's used if the patient has healing abilities, but in the neck it's most dramatic. And we'll go over some examples of that. So this structure here can be easily palpated and is very important and vital for the function of all the special sense organs, are supported by this neck. And a big source of what they call migraines is related to instability of this neck. Although migraines are mixed, you can have a dysbiosis, a yeast, toxicity also cosmic, so you need to fix all the layers. Next slide. Normal shoulder ligaments. Next slide. Ripped, torn, unstable ligaments. Tendons we're not illustrating, but it's basically the same thing. They're hooked to a muscle. They have a less supportive function. Ligaments are the primary stabilizers of joints, but they both are primarily collagen, and they both have a poor blood supply. Where there's poor blood supply, there's poor healing ability. Next slide. Reconstructed shoulder ligaments. So where do we inject? Well, this is from grants. You can bird book it. Any place that attaches. So you can do origins, you can do insertions. That's all fair game. Elbow ligaments. Next slide. Torn and relaxed. We get a lot of experience in Wisconsin since we're machine capital. We're doing lots of repetitive assembly line and vibration type of things. Next one. And reconstructed elbow. Workers' compensation injuries in 1988 increased to 6.4 million from 6.0 million from 87, and the increase was due to repetitive work motions. This is not my opinion. This is the U.S. Bureau of Labor Statistics release. I'm just relaying the information. Next slide. The prevalence of carpal tunnel syndromes in the female supermarket checkers was found to be 62.5% of 1,116 respondents, as published in an article in the Journal of Occupational Medicine, 1987, December 29. So 62% of them had some type of carpal tunnel syndromes, the checkers. Normal wrist ligaments. Look how dense they are. You can't even see any bone on the dorsum. Now, I'm going to ask you a difficult question. If you do repetitive motion on a joint, is it going to get too tight or is it going to get too loose? Too loose we have. Are you sure? Now remember, they say carpal tunnel is, you see from the repetitive motion, the elements in the tunnel have swollen. And what we need to do is to say that God made a mistake and he put the transverse carpal ligament there and it's too tight. So if we cut that ligament, you're going to have more room in that and it's going to relieve the problem. So now we've cut your ligament. We said God made another mistake. He made a mistake in the neck according to the heart researchers. And he's now made this damn transverse carpal ligament. If you cut the ligament and you go back to the same job, is your wrist going to be stronger or is it going to be looser? It's going to be looser. Very hard concepts which we're developing today, and you guys are really sharp, catching right up. Go ahead. But funny, even the surgeons know this. Carpal tunnel syndrome, if followed, this is a quote, if followed by a return to the same traumatic environment, operation is often unsuccessful in controlling symptoms in such patients. Here's my buddies. The Mayo Clinic Proceedings, July 1989. A quote right from them. They say that it doesn't work. They go back to the same job. Wonder how it comes. Well, we'll see. Go ahead. It's in the literature. You just need to do research. The carpal tunnel arch is altered after carpal tunnel release. The transverse arch widens 10.4% or 2.7 millimeters after surgery. Really nice. And a direct relationship exists between the widening of the arch and the loss of grip strength. So it really helped that wrist. Made them stronger than dirt, right? And this is from, even the surgeons know it. They won't admit it because they don't read their own literature. The Journal of Hand Surgery, 1986, May. It's not mine saying that. Next slide. So with reconstructive therapy, we find that they get too loose on the dorsum. We reconstruct the dorsum, they go back to that same job. It's in my book, illustrations of it. They go back to heavy vibration and heavy twisting and wrenching. We're machine capital. We make the machines in Milwaukee. You might have a Ford or a Chrysler, but a lot of those parts that went into it are made in Milwaukee. Or your washing machine, a lot of they might be made in Newton, Iowa, but the actual parts many times are subcontracted in Milwaukee. So with reconstructive therapy, we never touch the ventral side. We strengthen the dorsum, give them a stronger wrist. That's how they get it. Now, this is mechanical carpal tunnel syndrome. If somebody here is waiting to shoot me down, this is mechanical carpal tunnel syndrome. This is not the carpal tunnel syndrome of type 6. This is not the carpal tunnel syndrome of rheumatoid arthritis. This is not the carpal tunnel syndrome of cortisone usage. This is not the carpal tunnel syndrome of mixed edema. What are those? Those are metabolic carpal tunnel syndrome, right? Metabolic dysfunction. This is mechanical. In fact, this whole lecture is on mechanical. But you can get metabolic problems so bad that you destroy the anatomy, and then you end up with a mechanical problem. So we're not saying that there isn't gonococcal arthritis, joint dysfunction, or other vectors, parasitic arthritis, or immunological arthritis as a primary etiology. If those etiologies get so that there's a mechanical problem, then reconstructive therapy can come in. Of course, you need to fix your cause and give them peroxide therapy or ozone therapy, homeopathy, all of them. Next slide. Or B6. Remember, fingers and toes have ligaments. You usually don't have to do much work on them, except for the thumb. They respond very quickly, except for the thumb. Needs a lot more work for it. So, benefits or indications, WIIFM, that popular FM radio station. Go ahead. Well, first of all, what can we get out of this? Well, the tissue and strength increased potential possible with reconstructive therapy can exceed 100%. For example, normal has to be defined as 100. How else can you define normal? I guess if you go to Harvard, you could define it less. But injured or relaxed, let's say we're at 20%. Like our fellow that couldn't get off the stool himself, he could be at 20% of normal strength and tissue. Well, with reconstructive therapy, we can do up to 40% more than normal. So therefore, our clinical results can exceed 100%. You're taking somebody down in the sewer here, all the way up to 140 max potential in strength and structure. That's a pretty good increase, over 100%. Excellent. The therapy can be successful regardless of how many years the problem has existed. We go back to the first lecture, you got dead cells. Well, you got to get those out. But if they're not dead and just torn up, ripped up, degenerated, well, we can grow new with this therapy. Next slide. The therapy is effective for osteoarthritis, spondylosis, regardless of its severity. Next slide. The therapy is effective for disc disease. Next slide. Loss of space. It even works for bone-on-bone arthritis. Next slide. Here's a man who had the chymopapine cure. You can see the normal disc height here. Here's a knife blade of disc height. Here's a knife blade of disc height. They did them extra good. They did 2 levels. We're really going to help them. What did that do for stability of the spine? For protrusion, may have helped. And what did it do for stability? They don't understand that, because remember, surgeons as strong as a bull and twice as smart. They don't understand that. Next slide. Here's a side view of this disc. And there he is. In his own words, he is 80% better with 8 sessions. More endurance, more strength, more function, less pain. This man worked for AMC. This is a number of years ago. See all the credit on the slide. 10 years of back pain, received surgery, we received manipulation, acupuncture, exercise. With reconstructive therapy, lifts heavy steel bars for AMC. He's a millwright. I guess they lift raw metal. No problem, no recurrences. Hasn't been back, that's one drawback on this therapy. It's not like medical annuity. If you do an orthopedic surgery, and Ben is an experienced anesthesiologist, you're going to see that patient in a year again, in 2 years, in 3 years. It's just it's like a medical annuity. Sooner or later, that time is going to blow up on them, and you have to do a replacement, more surgery. Go ahead. With reconstructive therapy, it stops it. You don't have recurrences with these people. A salient feature of people that need this therapy is that manipulation, adjustments, massage helps, but it doesn't last. So if you're not getting, if you go back to that baseline on that yes or that no, that's a no. You're not getting at the core of it. So if you're right back into this would be chiropractic annuity, you're just getting chiropractic, porosity session. Whatever type of manipulation, you're back in the same spot after you cough and fart or bend or something. You're not getting to it. And reconstructive therapy come in like a champ. The therapy is effective for failed bone, joint, disc, tendon, or ligament surgery. Here we have a man that I went over his x-rays and I said, look at this. He had a neural arch decompression, extra good surgery. And here's a Scotty dog going up his ear, going down his ear. Here's his snout. Here's his neck, the important part of the Scotty dog. Here's his forefoot. Here's his hind. Here's his back. Here's his other Scotty dog. Now look at this Scotty dog. They massacred it. They massacred that Scotty dog. They totally maimed his body. See? Big defect. His whole body's out of the Scotty dog. So he had, before we get with this lady, he had his spinal gutter, instead of being like this, just swollen. So we had to start out with neural therapy and biologic therapy, and then we started to do the reconstruction, because what else are you going to put in there? Well, the surgeons would start massacring his hip and start pounding it in there. But that's a clouder, and clouder procedures fail a lot of times, and it's hard to even get anybody to do a clouder because they know it failed. Or they take slivers out of the hip and pound them in your back. But anyway, he went back to activity, etc. It took us about over a year to reconstruct his back. Of course, it had been massacred and needed extensive reconstruction. This lady had 32 years of back pain. She had a laminectomy some 20 years previous to seeing me. Next slide. She had these huge spurring on her x-ray. They lived in Kenosha. It's about an hour from Milwaukee, almost on the state line. They drive this big Winnebago to Hog Heaven in Tennessee. Most people go north, they go south. And they have a little country home there in Hog Heaven. And her husband said that before they got to the state line, from the vibration of the Winnebago, tears would be rolling down her cheeks because she was in pain. Next slide. We reconstructed her back, and they built a new place down in Hog Heaven, and she brought in this snapshot, just bragging about her place and everything, and asked if I could have one of them. Well, it's a block home, and she carried 3/4 of all the blocks herself with that back. And she had 32 years of pain. Her husband said that he could tell she was better because she went all the way to Hog Heaven without tears rolling down her cheeks, etc. So with reconstructive therapy, along with neural therapy, if they're not better in every single parameter, something else is there, right? Because this is God's own healing mechanism. You should really get your patient in better than ever. I call it kind of like tide, stronger than dirt. You actually get them do things they've never done. You have problems with, one of your complications is the people that know them, when they start digging around in their lawn and start hauling around bricks, they say, Linda, or Ben, what the hell happened to you? Oh, I got these shots in my back, and my God, they're really something. We got cortisone, don't do that. That's the thing. Oh no, this doctor hates cortisone. He never uses cortisone. I got reconstructive therapy. Well, then you got the other problem, because the other medical authority, their neighbor, doesn't know what the hell it got. So that's one of your complications you have to deal with. So what? Go ahead. The therapy is effective as an alternative to surgery, just like neural therapy. Here's a normal cervical spine, except for straightening. Next slide. Remember the gal with the broken neck? C2 through C7, here's her neck. That's all fused, that's why it looks so terrible. Remember Mount Sinai said she had the herniated disc, you know what I mean, the rods, etc. Well, we did reconstructive therapy, she's fine. We did it years ago, at least maybe 5 years ago or so. She's doing excellent, no problems, go ahead, no surgeries. Again, with her we did the neural therapy, we got the immediate response, and then we reconstructed her. Go ahead. This man you saw in the film, University of Illinois wanted to replace his knee after they did a, remember it's medical annuity. First they're going to shave away parts. That can't work. It can't be better. I mean, that's like saying your car rattles and shakes, and they say, well, what's your problem with your car, Ben, is there's a little bit too much frame. The frame's a little bit too tight. We need to cut out about a ½ inch out of your frame. Is that going to make it stronger when you roll down the road? Well, how's it going to make your knee stronger, your back stronger? Yes.
Well, what about the meniscus, the cartilage? Does it rebuild the cartilage?
I believe it does, but one of the problems is, and I'll tell you, this man illustrates it. Remember the first lecture I said will and desire, and then I had that psychological thing? I rapidly got him into his zone of tolerance. I rapidly changed him over. He's not as good as what he should be. He should still be reconstructed to this day. He let me do about 10 of them. And one disadvantage of this therapy is it wipes out the pain. And by correcting it, it's not a pain treatment, it's a reconstructive therapy, so they think they're better. But actually you want to reconstruct them. He's not to his maximum reconstruction yet. And so, in answer to your question, my problem is, they think I'm churning, what they call in the stock market, if I want to do an MRI on them 3 years from now. And that they feel good, they're doing everything, and so I hope to get that data. Someday, I hope somebody will let me have that data to show that we actually do get the disc space back, but I haven't collected it yet. And then when I collect it, we know what they're going to say. Well, that's just anecdotal. This is for crying out loud, it's MRI. Well, it's still anecdotal. We only got a series of 1, I get a series of 2. They say, well, you only got a series of 2, I get a series of 3. They say, you only got a series of 3, I get a series of 10. But I'll give a shit. We'll just keep doing it. Go ahead. That's their problem, right? And there's a gal with the cervical spondylolisthesis. Totally well. Go ahead. Using both therapies. Therapy is indicated in any joint with pops, snaps, grinds. If it's popping, snapping, or grinding, it's too loose. Next slide. Not too tight. This man had 4 surgeries. Mayo's got him once. Marshfield, Willard Mecca's got him once. The University of Wisconsin got him once, and a private orthopedist got him once. He was wearing a big Lennox kill. Red hair, watch out. He was so he was a little bit allergic to a lot of the solutions, but he's playing volleyball fine after reconstructing it. No more effusion. It knocks out effusion. So the ankle that's swollen for years, gone. And it's from trauma with reconstructive therapy. Therapy is indicated in any joint pain which lasts longer than 6 months. If you can't heal it on your own in 6 months or with nutrition or homeopathy, you probably need to go to a deeper level. Next. The main effect of the therapy is increased function, strength, and endurance. The results are obtained without exercise. You cannot exercise a ligament or a tendon or a joint and make them stronger. Now, if anybody here is in sports medicine clinics, they want to choke me. Because they say, we have always told our people that exercise is what they need to do. Well, that's good, but you have to be in the, that's for mobilization. This is stabilization. It doesn't do anything for stability, it does mobility. If your only tool is a hammer, the whole world looks like a nail. Well, the best carpenter has more than a hammer in his toolbox. And there's more than one factor that is screwing people up. The whole world's not neural therapy, the whole world's not reconstructive therapy, yes.
So when you're doing this reconstruction, you have the immobilized or special drugging, you're then,
Well, your goal is to get more. And when you're a biological practitioner, you just want to beat the competition so damn bad it ain't funny. And so I just say, please don't do roofing at this time. Please don't do jogging. I mean, do you have to pound on your knee? Do you have to pound your spine? But if they're a salesman, they're in and out of the car, hell yes, do that. If they're working at the line, well, hell yes, do that. They gotta have money because they gotta pay me, and remember, it's a tit for tat. You know, I can't, only the government can rob you and not have a tit for a tat, right? Next one. The main side effect of the therapy is less pain. That's the main side effect. They see pain on our sign and inside the building, they see pain and think they gotta talk to me about pain. The most significant question that I ask the patient after a first treatment, after a second, after every treatment, are you getting stronger? Can you stand longer? Can you sit longer? With the knee, the key term is, do you have more confidence? Because that knee gives out, buckles on it. So you say, do you have more confidence in your knee? They want to talk pain. I don't want to hear pain. If they say they have more strength, more confidence, I don't have to ask about pain. I know they have more pain. See, because I'm treating at a core level, at an etiology level. Next. Therapy is indicated in any joint which is helped by a brace or support. What's a brace or support do? Well, it either braces or it supports. Or, more elegantly stated, it takes the function of the ligaments. A brace or support are artificial ligaments, basically. Next. Reconstructive therapy is the perfect brace or support. Yes, Peter?
What about scoliosis?
What about scoliosis? Coming, hold on. You're ahead of me. Therapy is permanent. Permanent. Once you create that anatomy, it's permanent. And by the way, it's stronger and better than normal. I've had 4 people, in fact, that broken neck, have had car accidents after I've reconstructed them. They do not injure, none of the 4 have injured the reconstructive area. They injure other areas. So again, it's like the Tide commercial. They're stronger than dirt. That area is just better than ever. So, you know, you got to increase your skills because get them onto an optimal health program and start working on their extracellular matrix or your basic substance to get them into other areas because you're done with them after this. Yes.
What do you do with patients who have areas in their spine or broken that are need adjustment? Do you do manipulations while you do the second therapy?
Well, somebody gave an answer to that. Oh, Bill Moore gave an answer to that. And the answer is a pig's butt called ham? Do I do manipulation as a pig's butt called ham? Next slide. Sure, you want to put it in place.
But do you do it at the same time you do it before?
You can do it before, you can do it after, you can do it later.
Do you do it simultaneously?
You can do it simultaneously. It's an independent therapy, but it's very complementary as long as I don't do rock and roll manipulation. The rack 'em, stack 'em, Captain Crunch. No, gentler and kinder. Remember, I had a pathologist in pathology say this: the higher the microscopic power needed to make a diagnosis, the lower the brain power. So the higher the force needed to do a manipulation or adjustment, the lower the brain power. And it's really the same way with reconstructive therapy. Because if you start increasing your proliferance, you're missing it. I've done all that, believe me. And it doesn't, it's more like architecture. Less is more. Less is more. So precise, gentler, and kinder stimuluses to give that body a helping hand is the rule. So my patients ask me, a lot of them are going to chiropractic, should I go? If he's doing rock and roll, I say, well, tell him to do activator, SOT, craniosacral, the indirect techniques, myofascial techniques, counter strain, Thompson technique, you have your written answer here. Something where they don't, because the active manipulation, you take them to their full range of motion and then you go through it. So you're going to the range of motion that's limited by your ligaments and then you can possibly make more work for us. You know, we just want to be superstars, we want to be making more work. Everybody else may want, well, not everybody, but the vast majority of practitioners making work for us. Why should we make more? Proliferative therapy or reconstructive therapy provides unsurpassed results in areas where standard therapies fail. Next slide. Such as compression fractures. In answer to your question, scoliosis, paralytic polio, muscular dystrophy, spondylolisthesis. This is an old slide. We got more. Congenital problems, genetic problems, Parkinson problems, things like muscular dystrophy, things like MS problems should also be added here. Next. This lady lost 5 inches in height. You'll see her later on. She's a mother-in-law of a chiropractor. You can see Dowager's. She'd just come out of an institution, a medical institution, couldn't take care of herself, couldn't hold her head up, couldn't get around. Next slide. There's a side view. She was only 5 foot higher maximum. She lost 5 inches. And you'll believe it when you see it. Title of Wayne Dyer's new book. You'll believe it when you see her spine. It's incredible. Anyway, she's totally independent. We did her several years ago with reconstructive therapy. Go ahead. How do we get that? Well, the response to gravity causes structures to become shorter and wider. Okay, everything's real complicated about this. But gravity pushes you down, sucks you into the earth, and gets shorter and wider. Go ahead. Well, reconstructive therapy is like scabbing in carpentry. You know what that means? Any carpenters here? Scabbing in. Your big support has got a crack in it, and you can't remove it because of cost factors or whatever. Well, the carpenter says we can scab in. So they put a 2x4 on this side, nail it in, and a 2x4 on this side, and splint it up. Well, reconstructive therapy does, in essence, the same thing. We're not treating the disc directly, particularly in the spine, because you get into danger factors. Should introduce there that death and paralysis have been reported in the literature from reconstructive therapy. So the serious therapy, you need to know what you're doing. However, the skilled and understanding practitioner, for them it's safer than a shot of cortisone or penicillin. You know the devastating effects of cortisone and penicillin. But reconstructive therapy actually holds them up by a scabbing in process. Is that scoliosis enough for you? Good enough? Okay, let's get a side view. I want you to check them out. Next one. Is that good enough scoliosis? And he's standing straight. Okay, that's straight, right? Well, it is. Anyway, they're okay if they don't have pain, but if you have pain, you get, cramps up to here. Not with reconstructive therapy. He's still bent. I mean, to get them, and we have it in the book, you can get them when they're pliable, when they're a kid. With manipulation and reconstructive therapy, they don't even have to go into it, which is interesting. That's in my book. But he was painful, but by reconstructing his entire spine, he lives a normal life. And again, I have the problem in that they get better, and they think of me with pain and needles. They come to me for pain and needles, so I'd like to x-ray him again in about 2 or 3 years and see if we got the osseous changes and actually got his disc thrown out. Dr. Thompson.
I do a lot of scoliosis and maneuver I do with some kids from the age of 12 to 16. I get them an 80%
Yeah, if you can get them when they're soft, he's just reiterating what's in my book, and he's got more of the kid population, got more of a charisma. I find that at 12 to 20, there tend to be bad patients to treat because they have to submit, and they tend to say no when they find out.
Get the parents involved. I had one girl at the age of 16 in 1 year doing instrument after themselves straight to the spine, sitting there themselves.
Now, I have done 3 13-year-olds. I've done their necks on 3 13-year-olds. In fact, you're going to see one of them. But I just find that age, it's a transition age. You're not an adult, you're not a kid, and the psychic influences do not allow you a lot of times to get doing your needles. But I have done kids. In fact, I'm doing a 6-year-old now, which is very interesting. It's a congenital case. Next slide. This man had polio for 45 years, wears heavy braces on his legs, with reconstructive therapy to really his entire body, except his TMJ. Did not do his TMJ. I've done his neck, done his shoulders, elbows, wrists, fingers, low back, hips, knees, and ankles. He's made significant improvement in his ability to ambulate. He still wears the heavy braces. His entire total low body is atrophy, just spindle atrophy from polio 45 years ago. Next slide. This man, wheelchair, what's the diagnosis? Dr. Ben? Close. Got an M in it, Dr. Ben. There he goes, MD, both got it. Ankle swollen, this right ankle swollen for 17 years. Was broken so severely, had to have metal implants in it. And they said they thought he'd have to cut it off with a single reconstructive therapy to ankle so he could get his shoe back on. We reconstructed his lower back and mid-back. He used to take 3 people, now this guy's 250 plus, 3 people to help him get upstairs. Because his shoulder girdle and pelvic girdle muscular dystrophy. Just doing his pelvic girdle, he can get upstairs with a minimum assistance of 1 person. It does not fix the dystrophy. It does not fix polio, but if there's anything that involves joint instability, it beats whatever comes in second by so far as funding. So I'm not saying it's curative for MD, and not saying it's curative for polio. It just reconstructs the joints, that's all. Okay. What's this? Yeah. Yeah, exactly. Spondylolisthesis, right. This is an executive that I treated. I didn't make much money because he got a symptomatic result in 2 times. So that's part of the downside if you're right on giving a very effective therapy. They quit on you before you get a maximum strengthening. But he's doing everything, golfing, swimming, doing slave labor, even though he's an executive. Next slide. Well, they get out and run around in their lawns, you know. Here's the close-up. Go ahead. Now here, we have a spondylolisthesis with about a grade 2 slip, see? Here's the line, here's the back of it. Then we got this nice thing here with some big spurs, some wedging. Excellent results with reconstructive therapy. These are great cases for us. What's the diagnosis here? This is a hard one. Ears are, very good. Ears are lower, wider set eyes, face. We could say we don't have his hands. He doesn't have salt and pepper, but he's actually got a Klinefelter, which is related down type of thing. Extra number, extra amount of genetic material. We have multiple problems. We entered in his abdomen because he was having dyspepsia, etc. After we got going there, we noticed he had a hell of a wambly gait. Just kind of wambly is how I would describe it. Very non-determined type of gait, so we started on his neck reconstruction, a marked difference in his gait in the very first session. And then we did his low back and we did some of his ankles. So as a part of his multiple defects, he had ligament laxity. I'm not saying it cures Klinefelters, but it sure as hell helped his gait and his spine, etc. Yeah. What's that? Is that enough scoliosis for you? Well, this is actually traumatic scoliosis. And this is one of our friends who died when the book was in publication. This is in the book. But he fell off a telephone pole being a lineman for the county in Falls Creek, Wisconsin when he was 20 years of age. And he fractured multiple compression fractures, as you can see. It's a weird looking spine. And he was paralyzed, lost bladder control, and they said, well, you're just going to be paralyzed. Well, he didn't accept it and sought osteopathic care initially, and then he went to osteopathic college, got introduced in the 1940s to reconstructive therapy. As a result of manipulation and reconstructive therapy, he was able to play golf, nearly shooting his age. and living a full and active life, recovering from paralysis and multiple compression fractures and disability. He's crooked as hell, but you know, when you get somebody like that and they're turned to rock, you would generally stay as a rock, but you can still reconstruct around that rock, these views, as a result of that stability, and resolve their pain and increase their mobility and their function. Gerald?
Did his bladder dysfunction for
That was many years ago. He claims, this is Dr. Middlestead, do you recall him? He claims that if this therapy was bad, he'd certainly be dead, because he's had it repeatedly for years and years. This illustrates an important point. In cases of severe anatomical loss, it is recommended that they get periodic touch-up, because they're putting hyper stresses, and even though you build them up, you know, he's compressed severely, and he's got, therefore, severe anatomical loss. They should get touch-ups periodically after they reach their max, and they're every 3 months. It depends on the patient, 3 months, 6 months, they should get a touch-up. Next slide. Here's another one. It's not very much of a moneymaker, but bunions respond very excellent to reconstructive therapy. You will not change the deformity, they'll just wipe out their pain, and you won't make very much money from it. Certainly the orthopedist and the podiatrist make a ton of money, more than what you will, doing their foot, but you'll get them out of pain and dysfunction and find them very quickly by reconstructing it. Next. This is maybe Faber's sign. I don't know that anybody's identified this. But look at this. Look at this. There's one line that goes clear across. There's another line that goes clear across. He's got one over here. And he's got another one here. So he's got 2.5 lines that go across his neck. Next slide. Well, from doing so many necks, we find that each line, if they get a complete line across there, it corresponds with a disc disruption. We're going to lose height. You're going to have slack in your skin, right? You lost height. It makes a crease in the back of the neck. So you just look at somebody and they got one crease, two crease. You got 2 levels of disc degeneration. Right every time. They got just a little one. You're starting disc degeneration. He had Parkinson's. He has Parkinson's. What's the salient feature with Parkinson's? Well, the tremor. That's another subject. What's the other salient feature? They walk from here to the snack bar, and they are fatigued. They've had it. Well, if you're doing this all the time, and then you're going over to the snack bar, is that a hell of a lot of work? I mean, yeah, to do all this crazy stuff. I'm getting tired of doing it. So you split their neck up, you've increased their endurance tremendously. And they're still pill rolling. They're still troweling. They still got the difficulty with intention, you know, the hesitancy. But you just increased their endurance to beat the back. So reconstructive therapy can even help Parkinson's. This lady had systemic lupus erythematosus. We got a no answer when we tried reconstructive therapy. We tried a different solution, we got a no. What's the history? I find lupus, the history is almost uniform. I don't have a lot of them, but every single one that I have, antibiotics, 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 antibiotics. Then they get a rash and somebody's ahead of me. Then cortisone to seal that crap in there. Then wait 6 months, you got lupus. Or rheumatoid can also evolve with that same history. I've seen it more than once. She wouldn't take any intravenous, but she would take all the herbs and spices and stuff out of the jars and homeopathic. So we worked on, this is the longest detox that I ever did on anybody. Well, and then went to reconstructive. It took me 2 years of detox. And her bowels, she wasn't pooping, she had dyspepsia, had poor appetite. You know, we had to do the whole thing. She had a big baseball carotid here that was hard. And she was telling me how the doctor said, well, that's normal, that's normal. Pretty big and hard. Well, anyway, we got her bowels going, we got her pooping, we gave her glandular substances, homeopathy, everything oral. She wasn't doing any intravenous. And that thing went away, and then we did the reconstruction. Within 6 months, she was shoveling the stuff in snow. Her migraines were resolved. She had a failed back surgery 15 years previous. She had migraines for 10 years. So, if you get a no, well, do something else. Stroke. Somebody asked stroke one of the days. What's this? This is a post-status stroke. And the medical doctors and the osteopathic doctors are not capable of reading their own damn textbook. Okay? Not that they're impaired functionally, that they can't read either. But what do you do with the stroke? What I was taught is that you give them a $5 sling. He didn't have any slings. So what happened over a number of years is he had a real good stroke, so this thing contracted on him, and just hanging there, no movement. So what happened to his arm? Fell down, stretched. They had tremendous pain in that arm. So what did we do? We just stood behind him, and we just prayed with his arm. How's that feel? Well, that feels better. Well, I'm going to do a very difficult treatment now. I give him a $5 arm sling, $5 whole dollars that it cost me. But then it showed how to do that. Okay, where'd that go? Well, nobody likes an arm sling. It's better. Well, those are all stretched out. We need to do reconstructive therapy. So we reconstructed his shoulder. This guy's a mess. We worked him all over. He had other problems too. But anyway, we got his arm pain away that had been static for years. Why? Because the left arm just hang there. The other thing is they got spondylolisthesis. How many people with spondylolisthesis come in with a brace? Almost none. That's primary. That's even in their books, isn't it? And they don't come in with a brace. So anything that's helped by a brace or support, hey, you know reconstructive therapy is going to be an ace because it's the perfect supportive brace. So, let's go with the orthodox pathway. This is like a patient care flow chart of medicine and surgery, method of joint treatment. If I'm wrong, please correct me because this is in the book too. We start with normal joints. We have a joint problem. We should give an orthodox treatment. We give the antis, right? Motrin, aspirin, Valdine, something like that. When that doesn't work, we send it to a physical therapist. We give them careful exercises. We give them physical therapy, ultrasound, wax, some type of electric gizmo, blinking lights, wonderful. When that doesn't work, then we give them cortisone, either oral or injection. You need cortisone. That's what our athletes get. Oh yes, I want some too. So give them cortisone. When that doesn't work, we give them mini surgery, which is arthroscopy. When that doesn't work, because it can't work, because it's going to make you weaker, how can taking out parts even on a microscopic basis give you more stability? Can't. Or more confidence in knees, for example. So we give them more cortisone, we give them more anti-inflammatory medicines. When that doesn't work, we do maxi surgery. What you need is that a joint is destroyed. We need to do plastic one in there. This is really good. We put a plastic one in there because it has a different specific density, as well as the immunological things are being resolved. It's going to get smaller, get worn away. And they've admitted for years. 5 years. We don't want to do real old people, so they die before they need another one. But they keep doing them younger and younger. I was on a Los Angeles radio program that wanted to do a gal 30-some years of age, and I ran into patients in my practice, 30 years, they're implanting them already. So then they do re-implants and surgery of artificial. I was really kind here, because this is in the book. You should put another arrow, and this is Pine Lawn, Holy Cross, Wisconsin Memorial, is the step after that. But I left it out. Next one. So, that is the bubblegum, baling wire, sealing wax method of joint treatment, as well illustrated. Next slide. But we have choices in life. With the biological method of joint treatment, we start with normal joints. First, we rest, optimize nutrition, detoxification, manipulation. support, bracing. If that doesn't work enough, intensify it with careful exercise, physical therapy, bracing, rest. If that doesn't work, non-surgical reconstructive therapy gives you 40% more strength and structure than normals. So we actually don't go to normal, we go to super normal. We get a super joint. Next slide. So, if this is so damn good, your patients are going to ask you, well, why the hell aren't more doctors doing it? I mean, this is the best thing around. Well, here's the answers. It uses no patented drugs. So there's no pharmaceutical backing. There's no salesman there making big money on it. Everything is non-patented stuff. It is not taught in medical schools or in residency. It's only taught in special preceptorship postdoctoral programs. So they have to want to get it and they have to seek it out. And the fourth is that therapy skills are an art. And they go through this little emotional shock type of thing, and they find that when they get into this type of stuff, they find that most of the stuff they learn in medical school is garbage and lethal and toxic, causing patients problems. Next. Big factor is that this is therapy of the future today. Growth factors are excreted from those white blood cells, mitogenic factors, which by the year 2000, Genentech themselves has at least 7 or 8 things that are in the pipeline that are growth factor stimulants, or mitogenic things. It's going to change all of pharmacology by the year 2000. They're no longer going to be blocking. They're going to be moving over. But remember, human growth hormone, the first growth factor that was released, was $350 a dose. So it's going to be very high cost, whereas it cost us 20 cents to make our own endogenous growth factors with reconstructive therapy. So this is truly the therapy of the future today. The book, 330 pages, just come out. Next slide. Biological therapy, reconstructive therapy improves so-called incurable cases. We got a little bonus. We're in a bonus situation now. Normally I end there. This is the lady that lost the 5 inches in height. Now, we x-rayed her with picker, state-of-the-art, high KV. We used the Fuji Super Cassettes. Then I took this to a graphic art place to make the photo from it. And we had to enhance where her cortices were because you couldn't see anything. That's how bad her arthritis is. This is top quality of an x-ray and top quality reproduction of it. I don't know how you get any better quality. Everything's as good as we can get it. Next. And here she is from the AP. Now, what do those arrows represent? Anybody? What am I showing with the arrows? See how good you are. I'm showing her structure, what has happened to her. No, it's too lateral for spine.
Soft tissue calcification.
No. These are her ribs, and when you lose 5 inches, where do your ribs go? Into your pelvis. So I plan on writing a separate paper here, but her ribs are actually in her pelvis. And these are, the arrows show her ribs. Every damn vertebra is collapsed. Well, she's doing well. She's still deformed and everything, but she doesn't have pain. She's doing everything she wants to. Next. Remember, reconstructive therapy uses the body's own natural mechanisms. Next. Biological reconstructive therapy. This is a big reason why more doctors don't know about it. It costs 1/10 to 1/3 as much. Well, hell, you can't buy Mercedes and California Beamers if you slash the hell out of the cost and don't get to operate on them every 3 or 4 years. So it only costs 1/10 to 1/3 of what other treatment costs are. So we must make a decision. Do we want to block pain or do we want to stimulate healing? Reconstructive therapy definitely puts this at the crux. Do you want to use growth factors and stimulators, or do you want to use blockers? And no. Biological reconstruction therapy permanently rebuilds the structure. They're stronger than dirt. And that guy's in trouble. You see it? And this is a photo of a polar bear taking a urination in a snowstorm. And that's the end of it. Thank you very much.
Thank you very much, Bill. I hope the dentists are all happy with that because they can apply this to the joints and also to the teeth. And we're gonna see that tomorrow, I think. This afternoon, I think what we're gonna start out with is a patient demonstration, and we'll have our team from Columbia plus Dr. Faber, and I don't know what time Dr. Klingberg's getting here, but we'd like to have everybody contribute to the synthesis of how you do a diagnosis. And just what we want, like what we did yesterday was excellent. And then I'd also like to have somebody with a jaw joint problem, so they can do that. Anybody got a problem? Hit somebody in the jaw area.
Did you bring gloves today?
Yes, they have gloves. Yeah, still those yellow ones though. Okay, so why don't we come back at 2 o'clock? What time is it now?
21.
2:30.